According to Wilson et al., the sudden sensory deafness is defined as hearing loss greater than 30 dB in three contiguous frequencies of pure tones that occur within 72 hours. This sudden sensory hearing loss first defined by Dr. D. Klein in 1944. So first description given by Dr. D. Klein in 1944. Second definition given by the Haberkamp that define this 30 decibel is decreased to 20 decibel in Haberkamp definition. And third definition given by, that is broad definition given by Japanese Ministry in Welfare, that is sudden onset sensory hearing loss, usually severe, which is unknown etiology, and that may occur within 72 hours, that is unilateral, and there is no history of recurrent episodes, that may be associated with tinnitus and vertigo. And this sudden sensory hearing loss is equal in male and female. Mostly it is unilateral, about 90 to 99%, and right or left side equally affected, and incidence is about 5 to 30 per lakh population worldwide. Most common age group affected are between 50 to 60 years of age, and most common cause of, that is idiopathic or that is unknown cause of etiology, about 90 to 99%. Rest pathology can be diagnosed about 1 to 10% cases only. Etiology may be infectious like mumps, common in children. Adult common virus is herpes and meningococci. Other may be HIV, Lyme's disease, syphilis, meningitis are the common infectious causes. Otologic causes may be venous disease, autoimmune conditions like Cogan syndrome, rheumatoid arthritis, vaginous granulomatosis. Trauma like barotrauma, ear trauma, or head trauma are common causes of sudden sensory hearing loss. Vascular causes may be because of cerebrovascular stroke or CV stroke diseases. Neoplastic may be neurofibromatosis, schwannoma, angioma, and meningioma. Other causes may be genetic causes, mitochondrial disorder, ototoxins, drugs, and pregnancy are other known causes of this sudden sensory hearing loss. Other neurological causes may be multiple sclerosis or CP angle tumors. Metabolic may be because of diabetes, and hypothyroidism because of neuropathy. So these are the known causes of sudden sensory hearing loss. These all may be differential diagnosis of sudden sensory hearing loss. But clinical examination, otological examination, neurological examination, MRI contrast, and CT scan for previously operated ear cases rule out most of these pathologies, and most of the common pathology will come out as a idiopathic sudden sensory hearing loss. There are 5 signs of bad recovery or bad prognosis. These are: if hearing loss is more than 50 decibel, if this hearing loss is more on the high frequency than the low frequency. Third one, this hearing loss is associated with vertigo. And fourth one, if patient come to us more than 72 hours, means late presentation, and patient having comorbidity like alcohol and smoker. So these are the 5 signs of bad prognosis. Low frequency hearing loss, and if it is less than 50 decibel, are good sign of the prognosis. According to evidence, there are 3 effective treatment of this sudden sensory hearing loss. First is steroid, second is hyperbaric oxygen therapy, and third one is the heparin. So these are the 3 things which are effective in the sudden sensory hearing loss. What is best approach? Best approach, you have to give single dose of injectable Dexona in first sitting, then followed by oral systemic therapy. In oral systemic therapy, treatment of choice is the methylprednisolone, followed by prednisolone, followed by Dexona. So these are the sequence of oral medication. If patient not responding within 5 to 10 days, then you have to add transtympanic Dexona therapy. In transtympanic, Dexona is better than the methylprednisolone because Dexona is less irritant, and you have to give 1 milligram in 1 ml transtympanic Dexona and you can put gromate in the posterior inferior quadrant and give Dexona, because if you want to repeat the dose, so you should not take patient again and again in OT. You can apply Ciplox D ear drop in subsequent visit on the ISSHL of this gromate site. So this will help to taking the patient again and again in OT for giving the Dexona dosage weekly. So better to keep the gromate on first sitting, and you can repeat the dosage without taking the patient in the OT. If patient is diabetic and severely hypertensive, then you have to go for straightway transtympanic Dexona therapy. Recovery with steroid therapy is increased about 60 to 85% of cases without steroid, which is less than 50%. Second effective therapy in sudden sensory hearing loss is hyperbaric oxygen therapy. In sudden sensory hearing loss, hyperbaric oxygen therapy you should give with the steroid only. Without steroid, it is not effective. So, hyperbaric oxygen therapy should be added with systemic or intratympanic steroid therapy, and it should be continued till the hyperbaric oxygen therapy is given. And last therapy is the heparin. You can add blood thinner with these steroid and hyperbaric oxygen therapy. In some cases like vertigo cases, you can give beta-stine in full dosage, mostly 24 milligram TDS dosage. So that will help in the vertigo patient. If patient present to us with tinnitus and sudden sensory hearing loss, so there is no treatment for tinnitus as such till now.